Bismillah ar-Rahman ar-Rahim. Welcome to all colleagues and attendees of third ISMA International Webinar. This year we have many international speakers. Today, this night we have an elegant speaker and outstanding lecture, interesting topic, future perspective oral anti-diabetic medication. We are happy the second time to meet Professor Francesco Giorgino, Professor of Endocrinology at the University of Bari. He is the current president of Italian Society of Endocrinology. We meet Professor Giorgino for the first time, the second time, the first time where the injectable anti-diabetic medications is an interesting one, and we have many experience and good feedback for this lecture. Today we have a future perspective oral anti-diabetic medication. We hope, thanks for your time and thanks for kind accepting our invitation. We hope to see you in the future physically in Ismailia, the beautiful city in Egypt. I leave the introduction of this meeting to my colleague, Professor Ahmed.
Thank you, Professor Ihab, for this presentation, presenting Professor Francesco Giorgino. And we're very happy that he is with us for the second time in ISMA event, this time third international ISMA conference. And actually he will have two talks with us. The first one about future perspectives of oral anti-diabetic medications. And I think he will focus on SGLT2 inhibitors. Then he will have another presentation about future perspective of injectable anti-diabetic medications. Diabetes and cardiovascular disease are entangling nowadays, so it's important for diabetologists, endocrinologists, and internists and cardiologists, of course, to know what's going on for the future perspective of oral anti-diabetic medications. And I'll leave the microphone now for Professor Giorgino, who is joining us and dedicated some time from his precious time for us. Professor Giorgino, welcome.
Thank you very much for the kind introduction. I'm really very pleased to be in this meeting and to share with you some thoughts about future perspectives in therapy of type 2 diabetes. I will, as has been just introduced by the chairman, focus on SGLT2 inhibitors because, of course, these drugs are not new, but the properties that have shown is really something that is making us think more and more of using these agents, not only in people with type 2 diabetes, but also beyond type 2 diabetes. So this is the disclosure slide that, as usual, is shared with you all. And I will start with this very simple data, which highlights how diabetes is, of course, increasing, and it is expected to affect more than 500 million people by 2045. And as diabetes is increasing, unfortunately, also some of the comorbidities or complications of this disease are increasing as well. This is the case for heart failure. So heart failure is, as we know, a leading cause of hospitalization in older adults. And it is also, unfortunately, one of the situations that will lead to excess death, also in the population with type 2 diabetes. Another problem associated with diabetes and its expanding growth is chronic kidney disease. We know that there is more than half of patients with type 2 diabetes who will develop this complication. And eventually, again, this will also lead to end-stage renal disease in a significant proportion of these patients. Now, the important issue is also that these two complications interact with each other, creating a vicious cycle. So heart failure is more severe in diabetes and is also favoring chronic kidney disease and its adverse outcomes. And at the same time, people who have impaired kidney function are at increased risk of heart failure. So we definitely need agents that will target these complications. And as you know, over the last few years, we have learned a lot from the cardiovascular outcome trials and also from other large trials investigating the safety, but not only that, the efficacy of some of the new agents to treat diabetes, including GLP-1 receptor agonists SGLT2 inhibitors, and DPP4 inhibitors. Now, these agents have been investigated in populations with different features. So most of the studies were really enrolling people at high cardiovascular risk and probable cardiology type of type 2 patients. There were, however, some trials investigating people at lower risk, so with a lower proportion of cardiovascular disease, what we would think patients for a typical primary care setting. And a couple of studies have also investigated the effects of these agents in people who could be considered as probable nephrology type 2 patients. This is particularly the case of Credence, a trial with an SGLT2 inhibitor that we will focus on a little later. So we know that now it's more than 5 years that the effects of the empagliflozin in EMPA-REG have been disclosed. We were really surprised in a very positive manner to see not only the reduction of the primary cardiovascular outcome with this agent, but also the marked reduction of cardiovascular death from any cause, and specifically, what was not expected, a marked reduction of the hospitalization for heart failure. And since then, we have appreciated that these effects are not exclusive of empagliflozin. Indeed, the reduction of MACE adverse cardiovascular events, the primary outcome in these trials, was also seen with canagliflozin in CANVAS and Credence. The reduction of hospitalization for heart failure was consistently seen in all of the cardiovascular outcome trials, as well as in Credence with these agents, the SGLT2 inhibitors. So really, the reduction of this very adverse, very negative outcome of the heart failure condition is something that we can appreciate in all trials in which an SGLT2 inhibitor is being used, including the very latest trial with ertugliflozin, VERTIS-CV, in which, as you can appreciate, also here, a 30% reduction in the hospitalization for heart failure was seen, and this was statistically significant. Now, there are some questions that really pertain, I would think, to the next future. Which are the heart failure patients that could benefit the most from using these agents? People with a reduced ejection fraction of the left ventricle, or people with other types of heart failure? But there's not a definite answer to this question, but there are some preliminary analyses that come from subgroup investigations of, for example, DECLARE. In DECLARE, it was observed that there was no difference for the hospitalization for heart failure, whether the patient had reduced ejection fraction or not a reduced ejection fraction type of heart failure. You can appreciate that the p-value did not show any evidence for interaction. However, as you consider the cardiovascular death outcome specifically, you can see that this seems to be prevented more in people with a reduced ejection fraction, not with other types of heart failure. So it's not totally clear which kind of heart failure would benefit the most. Probably this will be a quite homogeneous and broad benefit, but maybe for some specific outcomes, the reduced ejection fraction is something that we can appreciate as a clinical setting in which the benefit is very evident. I was alluding to the broad benefit of SGLT2 inhibitors in people with different kinds of cardiovascular disease. And indeed, it is a broad benefit because regardless of whether the patient does have or does not have established cardiovascular disease, these are the subgroups from the trials I have introduced, people who have atherosclerotic cardiovascular disease or only multiple risk factors, so no clinical evidence of the disease, you can see that the reduction of the hospitalization for heart failure is exactly of the same magnitude. So this means that also lower risk patients would benefit for this particular outcome from using an SGLT2 inhibitor. And similarly, whether the patient has a previous history of myocardial infarction or does not have any history of myocardial infarction, you can definitely see that the benefit is there. So again, it seems to be quite universal benefit that does not take into consideration the level of cardiovascular risk of the patient and does not even take into consideration whether the patient has or does not have a history of previous heart failure episodes. Again, looking at the data from these trials and stratifying the patients for history or lack of history of heart failure, you can definitely see that the prevention of hospitalization was of the same magnitude, again, about 30% reduction in both subgroups with no evidence of heterogeneity. What we have seen so far is data that refer to the clinical trial setting, and therefore another question that is already started to be answered is whether these benefits may extend to real life, to real world populations, to settings in which we have patients that are more heterogeneous, probably at lower cardiovascular risk. And the question again is the benefit there also? We have published data from the CVD Real 1 and CVD Real 2 program. These are studies, observational studies involving a number of countries in the Northern Europe, in USA, as well as in some Asian countries. And I think that it is quite evident that the benefit is also seen in these observational trials or studies. We have recently conducted a study in Italy, which was published a couple of weeks ago in Diabetes, Obesity, and Metabolism, looking at data from two regions in Italy, Lombardy and Apulia, which is the region I come from. We have investigated what happened from 2010 to 2018. And we have conducted this analysis looking at the effects of GLP-1 receptor agonists as compared to other oral or mostly oral anti-hyperglycemic medications. You can see that some of the known benefits of GLP-1 receptor agonists, for example, on death, on cardiovascular disease, on acute coronary syndrome, on peripheral vascular disease or lower limb complications, is seen also in these observational data sets. But we have also examined and investigated what happens if the patients are exposed to SGLT2 inhibitors as compared to other anti-hyperglycemic medications. And you see, again, a very interesting positive profile, which shows benefit for multiple outcomes when people are exposed to SGLT2 inhibitors. Reduction of death from all causes, reduction of cardiovascular disease, reduction of heart failure, as you would expect considering the properties of this particular class of anti-diabetes medications. I was also surprised in a positive manner, again, from seeing these effects of dapagliflozin in the DECLARE trial on atrial fibrillation. Probably I should not be that surprised. If you improve the hemodynamics and you make the heart work better, you can probably reduce the risk of arrhythmias. This was seen in DECLARE, and this involved a reduction of the first event of atrial fibrillation as well as the additional event. The first event was reduced in a statistically significant manner. The additional event showed a trend to a reduction. But it is interesting to see the effect of this SGLT2 inhibitor also on atrial fibrillation. Which are the mechanisms behind these protective effects? This has been long investigated now. Still no unique or specific mechanism has been identified. For sure, it does not rely on reduction of glycemia, as was shown early in the EMPIRE trial. The reduction of HbA1c contributes to only 3% to the benefit, for example, on reduction of cardiovascular mortality. hematocrit increase, which is something that would probably provide more oxygen to the tissues, is a more important factor and seems to mediate about 50% of the protective effects of empagliflozin on cardiovascular mortality. But we are talking about non-glycemic effects, something that is beyond the ability of these drugs to lower high blood sugar. And indeed, in this interesting cartoon, which lists the different hypotheses that have been suggested to explain why SGLT2 inhibitors are cardioprotective, you can see a number of mechanisms that have been suggested. I will just briefly mention the change in the metabolite utilization by the myocardial tissue, which will reduce fatty acid oxidation and improve oxygen consumption. I will talk about also the reduction of the afterload and the preload, which will improve the cardiac performance in terms of contractile activity. The increase in oxygen supply, which could be also the consequence of an increased synthesis of erythropoietin, and the restored mitochondrial calcium handling, which is probably important also to explain the reduction of arrhythmias, as I noted a minute ago. And finally, let's not forget that with a mechanism that reduces glucose toxicity, the tissues, including the heart, will benefit from reduction of oxidative stress. So still a lot to think about and probably to research on. But it is a fact that these effects are seen beyond the ability of these agents to reduce high blood sugar. And so this is why we have now two important studies that have a different inclusion criteria, the DAPA-HF and the EMPEROR-reduced, which are both conducted with an SGLT2 inhibitor, which is dapagliflozin for DAPA-HF and empagliflozin for EMPEROR-reduced. And both include a population that, regardless of diabetes, has a diagnosis of a heart failure with reduced ejection fraction of the left ventricle, lower than 40%, in addition to elevations in NT-proBNP as a marker of heart failure. This important note here that the population is not necessarily a population of people with diabetes is something that we have to consider very carefully. Indeed, in these studies, DAPA-HF and EMPEROR-reduced, the SGLT2 inhibitor was shown to reduce the primary composite, which was cardiovascular death, heart failure hospitalization, or urgent heart failure visit in DAPA-HF, cardiovascular death, or heart failure hospitalization in EMPEROR-reduced in a statistically significant manner. There was a reduction by approximately 25% and a very low number needed to treat, about 20 people to be treated for the length of the study to avoid one of such primary composite events. And as you consider the subgroups or the subtypes of different disease conditions in this trial, you can appreciate that the benefit in reducing the hospitalization for heart failure and cardiovascular death can be seen regardless of whether the quality of life at baseline was good or poor, regardless of the background heart failure therapy, whether involving a device or only drugs, regardless of whether her renal function was markedly reduced or overall preserved, regardless of the prior heart failure history, whether there was or not another episode of hospitalization. As we have already noted, regardless of whether the patient had diabetes or did not have diabetes, and also over a broad spectrum of left ventricular ejection fractions and with the different age of the patient. So it's a universal benefit that is quite evident, in these people who have heart failure with reduced ejection fraction. So now we have for these agents the possibility to show that they do not only prevent the occurrence of cardiovascular events, specifically heart failure hospitalization, as was shown in the cardiovascular outcome trials on people with type 2 diabetes, but they can be considered as a therapeutic tool to prevent heart failure outcomes in individuals with diabetes or without diabetes who have a diagnosis of heart failure with reduced ejection fraction of the left ventricle. So this is something that will, of course, extend the possibility to use these drugs to not only specialists of diabetes, but also cardiologists and other specialists that encounter patients with these problems. And the last part of this talk, I would like to focus on the other outcome that has been shown to be affected in a very favorable manner by the SGLT2 inhibitor class. I'm referring to the chronic kidney disease outcomes. There was evidence in these trials of reduction of new onset macroalbuminuria, clinical evident albuminuria, as well as of hard renal outcomes, including doubling of serum creatinine, dialysis and stage renal disease, and death from renal causes. This is what you can appreciate from all the trials, including MPEREG outcome, Canvas program, DECLARE, TIMI, and CREDENCE, which was focused on people with, as we will see, more severe renal impairment. This was always a reduction of the renal composite endpoint, which was statistically significant in all trials. As well, I was referring to CREDENCE because CREDENCE is the only trial which has a renal composite endpoint as a primary endpoint, and this was highly successful in showing that canagliflozin can reduce this renal composite endpoint and can, as you can see on the right hand side of this slide, stabilize eGFR, the renal function, over time. This declines with placebo, but it is more preserved with canagliflozin. We have recently looked at all these trials together, and it is apparent that they focus on the populations at different level of renal risk. Canvas, DECLARE, and MPEREG outcome are studies in which the population enrolled had relatively good renal health. There were a few patients with eGFR below 60, as you can see, and most of these patients did not have macroalbuminuria, but only normal or microalbuminuria. In contrast, CREDENCE and DAPA-CKD are trials in people with a high or very high, actually, renal risk. Most of these patients had eGFR below 30, and all of them had macroalbuminuria with a mean albumin urinary albumin to creatinine ratio of about 1,000. And regardless of the level of renal risk, regardless of whether the trial was a cardiovascular outcome trial or a renal outcome trial, you can see again that the use of an SGLT2 inhibitor was able to reduce the hazard ratio to about 40 to 45%. The only maybe exception is in VERTIS CVE, in which there was a reduction but not statistically significant. And the renal composite could be prevented with a relatively low number needed to treat. Of course, the NNT is lower in those trials that explore the effects of these agents in people at higher renal risk, such as in CREDENCE and DAPA-CKD. Which are the mechanisms behind this renoprotective mechanism. There's probably more delivery of sodium to the distal tubule because of the inhibition of SGLT2 transporter. This increased delivery of sodium affects the macula densa cells, which are cells that can release adenosine. Adenosine is indeed released upon exposure of these cells to sodium, and adenosine is able to mediate the vasoconstriction of the afferent arteriole in order to restore the glomerular hypertension or hyperfiltration, which is something that is required in order to normalize eGFR and protect the kidney over time. There's also suggestion that the lower renal stress of some cells that are involved in the erythropoietin production will result into the restoration of the production of this important hormone and its effects on the bone marrow in people with diabetes who are treated with an SGLT2 inhibitor. And you see here all of these mechanisms together that provide us with a very comprehensive picture in which there are multiple effects, indirect or direct, which would be absolutely beneficial to the kidney, especially as we consider the increased oxygen delivery, the restoration of the glomerular hyperfiltration, and the reduction of the pro-inflammatory pathways and the pro-fibrotic pathways that are activated in diabetes, but not only in diabetes, and could be prevented by use of SGLT2 inhibitors. So no surprise that the ADA standards of medical care of this year have identified three important high-risk people with type 2 diabetes: those with atherosclerotic cardiovascular disease or high risk indicators for this, those with heart failure, and those with chronic kidney disease. And when these three populations have been identified, you can see that in all of them, there is a very important priority to consider SGLT2 inhibitors as those drugs that could prevent these cardiovascular or renal adverse outcomes. So the evidence has been rich, and we definitely now have to consider these agents for people who have specific organ damage or high risk of organ damage. But as I have shown, this is not only the case for people with type 2 diabetes. There's an ongoing evidence being produced also for individuals who do not have type 2 diabetes and could be treated for heart failure outcomes or for chronic kidney disease outcomes with SGLT2 inhibitors. Let's have a look at the future, what the next 2 or 3 years will provide us in terms of novelty and perspectives. We have seen some of the studies that are listed in this slide already. Others I did not have the time to discuss, but let me make a couple of brief notes. For example, we are really awaiting the results of trials such as imperial preserved or emperor preserved, which will have explored the effects of empagliflozin, an SGLT2 inhibitor, in individuals with ejection fraction of the left ventricle that was above 40%. So those people, we will see whether will benefit from using an SGLT2 inhibitor as well. We also need to look at some additional studies as with EMPA-Kidney that will make a focus on the benefits of SGLT2 inhibitors in terms of reducing the progression of chronic kidney disease, as it was seen already in the APA-CKD. So you see that there is a very interesting scenario ahead of us, and not only cardiovascular outcomes or renal outcomes will be further explored, but there will be an opportunity to investigate biomarkers, mechanistic studies, and functional studies in order to validate the use of these agents, oral agents, to treat diabetes, not only for people with this particular disease, but also beyond type 2 diabetes. With this, I will stop, and thank you very much for your kind attention.
Thanks a lot for Professor Giorgino for this illustrative talk. We have a couple of short questions here. The first question is about, you prefer the European Society of Cardiology opinion about the early use of SGLT2 in a naive patient with multiple risk factors before?
Well, this is something that has been, as we know, suggested by the European Society of Cardiology guidelines. And there is obviously a discussion ongoing because it is not clear whether the benefit is seen also in individuals who are not treated with metformin. But I have to say that some analyses have actually provided evidence to that. What I'm trying to say is that in the cardiovascular outcome trials, the majority of patients were on metformin, and the benefit with SGLT2 inhibitor was seen on top of metformin. So this would lead to the conclusion that you have to use a sequential approach, use metformin first, and then go for an SGLT2 inhibitor. As you are asking, instead, there is some suggestion that the benefit is there regardless of the presence of metformin in the therapeutic regimen. I would think that this is the case because, as I said, there are some subgroup analyses that have shown that also in people who were not treated with metformin, you could see the reduction of hospitalization for heart failure with SGLT2 inhibitors, for example, as was seen in EMPEREG, but not only in EMPEREG. Now, the question, however, is that in people with type 2 diabetes, there's always a need to reduce hyperglycemia, and therefore you, at the end, will have to use multiple agents, including metformin.
Excellent. The second question is this a class, within the class, DABA or EMBA? Some prefer to use empagliflozin for secondary prevention with atherosclerotic cardiovascular disease, and we use DABA in a patient for primary prevention, a patient for heart failure. Do you prefer this classification or no difference between this drug and different group?
Well, I think that
there is any difference between DABA and EMBA.
I'm sorry, maybe we should, there was some bad noise. Maybe you should repeat the question because I think there was some noise while you were talking.
You hear me now, clear?
Yes.
Inside the SGLT2 class, is there any difference in clinical practice between the use of DABA and the EMBA? Some prefer to use the empagliflozin in a
I'm sorry, but I lost you. I did not hear you.
Can you hear now?
Yes, now I hear. Yes. I could listen to the beginning of the question, but not the end.
In your clinical practice, some prefer dapagliflozin and empagliflozin in selected patient. Some prefer EMBA in a patient with atherosclerotic cardiovascular disease for secondary prevention, and evidence based by EMPEREG. The other DABA for primary prevention. In a patient with atherosclerotic cardiovascular disease, EMBA is superior. In a patient for primary prevention, DABA is superior. What's your comment about this opinion?
Yes, thank you very much. This is an important question. I think that what you are describing is the consequence of the evidence that derives from the two studies, EMPEREG and DECLARE-TIMI, respectively. And the first study, EMPEREG, was in people, all of which with established cardiovascular disease, whereas DECLARE-TIMI with dapagliflozin was in people who were largely in primary prevention, so without established cardiovascular disease. So this is something that should be considered. But at the same time, I don't think we have any evidence that these molecules differ in their properties. So in my opinion, what has been seen with dapagliflozin and empagliflozin is very similar and is occurring regardless of the level of risk of the population or the patient that you are considering. So I would be surprised to not have any protection with empagliflozin in primary prevention, and we already know that dapagliflozin already works in both primary and secondary prevention.
Okay, yeah. Thank you. Can you listen to me clearly now, Professor Giorgino?
Yes, I hear you, but sometimes there are some noises.
Sorry about that. It's all technical issues. So a quick question. Now, cardiologist speaks about diabetes. Endocrinologist speaks about heart failure and with preserved or with reduced ejection fraction. Do you think there is a room for SGLT2 prevention of heart failure, maybe prevention of heart failure in diabetics or in non-diabetics rather than just treatment? Do you think there will be a day that the guidelines will carry to us that in patients who have a high risk or a likelihood of developing heart failure, either with preserved or reduced ejection fraction, it will be a chance for them, either whether they are diabetics or not, to have SGLT2 inhibitors, whichever empagliflozin or dapagliflozin, as a preventive tool for heart failure? Do you think so, Professor Giorgino?
Well, you know, we know so far that SGLT2 inhibitors will prevent heart failure outcomes in people with type 2 diabetes, regardless of whether the patient does have heart failure history or does not, whether the patient has atherosclerotic cardiovascular disease or not, has had an event, cardiovascular event like myocardial infarction. I showed you this data earlier. So in people with type 2 diabetes, the benefit is, I would say, universal. So also in people with early diabetes and no complications, if you are using an SGLT2 inhibitor, you will see protection against hospitalization for heart failure. Also because in diabetes, the heart is affected very early. And we know that there are also in some patients, there are some microvascular alterations that will reduce the compliance of the potentially treated in an early phase, so with prevention effects with an SGLT2 inhibitor. So this is what we know for people with type 2 diabetes. Of course, the number needed to treat in order to prevent one heart failure outcome event is lower in people with the previous diagnosis of heart failure, people at high cardiovascular risk, than it is in people who seem to be well, to stay in good conditions. But the benefit is there, so the relative risk reduction can be appreciated in all subgroups of patients. As we go outside diabetes, I don't think we can say the same, because so far we have data only from studies that have enrolled individuals with reduced ejection fraction of the left ventricle, as I showed, recalling the data from DAPA, HF, and EMPEROR reduced. So I don't think we can, at this point, speculate too much about what will happen if you are treating someone who is in good conditions, that don't have any disease, and whether this patient will be, put in a situation in which there will be lower risk for the future. I don't even think that such a study will ever be conducted. So we have to stick with the evidence so far. Outside diabetes, only people with clinical heart failure with reduced ejection fraction seem to benefit to a large extent. We will see what happens for other types of heart failure in the near future.
Thank you very much, Professor Giorgino. And we are closing this interesting session about future perspectives of oral antidiabetic drugs focus on SGLT2 inhibitors. And we will move to the next session. So, pure spot. We will move to the next session.